Welcome to this session about housing and dementia. It's organized by Alzheimer Nederland. And can everybody hear me in the back? Okay, that's correct. My name is Anne de Boer. I will be the moderator today. And I'm an advocate at Alzheimer Nederland. I brought 3 very interesting speakers with me. And I will introduce them in a bit. But they all have a different backgrounds and a different expertise. And they will look at housing with dementia on all these different perspectives. And I will try to link them together to one perspective for housing with dementia. Let's see if I can use this. Before I do that, I want to talk a bit more about the Netherlands. A short overview. We have an increase of people with dementia. I think this is what we hear in every presentation. Also in the Netherlands, the amount of people with dementia will increase. And with that, we see a decrease of people, healthcare professionals and their carers. And the ratio of people that work and people that do not work is decreasing. So there's less people in the Netherlands that can take care of people living with dementia. So we need a change. There's also an ambitious goal of their government, which is 300,000 new houses for elderly people. This is a nice thing for us because the amount of people with dementia now, 290,000, and the amount of houses that we want to build, 300,000, that looks quite the same. So what if we make all these houses dementia friendly? That would be very smart because then people can live longer at home and be more independent and have a better quality of life. So what does it mean, dementia-friendly housing? Well, we didn't know, so we asked people with dementia themselves. And this is what they gave back to us as what they want if we are talking about housing and living. They want their own home. They want safety and care close by if it's needed. They want a neighborhood that they know literally, but also just the people that are around there and they can find their own way. They want a community and they want activities. They want to stay autonomous and they want to be able to live together or alone, just a choice. This is what they wanted. If we ask them, what is dementia-friendly living for you? And we try to translate these wishes to a sort of utopia in our idea. And that's this drawing. We have made a dementia-friendly neighborhood, and we asked people with dementia, is this something that you like? They said yes, and actually I also like it. I would like to live here. So I think it's a good neighborhood for everyone, not only for people with dementia. And it's divided in 3 aspects of housing. The first is the built environment. The second is the social environment. And the third is care and support if needed. And those will be the 3 perspectives of today. And we will start with the social environment. And therefore I need the speaker Joost van Hoof. And then I need to look at my card, of course, to be very correct in what I'm saying. Because Joost van Hoof is a professor of urban aging at the The Hague University of Applied Sciences. And he will focus today on the dementia friendliness of the built environment, as defined by the World Health Organization. And this includes outdoor spaces and how we can improve the outdoor spaces to create encounters with others and to make public spaces more accessible. So give a warm applause for Joost van Hoof for the social environment.
So thanks, Anna, for the introduction. I think it's actually quite good if I start with a little disclaimer, because I'm still grateful to Alzheimer Nederland, the Dutch Alzheimer Society, for being a partner in my PhD, which was on aging in place, and that was in 2010 when I finished that. So we have a long history together. So I want to take you to another concept first, which is the age-friendly cities movement or agenda, which was set out in 2007 by the World Health Organization when they published this quite influential guide on global age-friendly cities with an accompanying checklist of essential features of age-friendly cities. And it's been around now for over 15 years, and 1,400 cities and communities and even national and provincial governments have joined the network. And in this network, there's a lot of commitment to create age-friendly communities and cities for all. And what they've done as well is publish this model, which you see in the right upper corner, where the age-friendly environment is described through 8 separate domains, which are shown as a flower here with the 8 petals describing the different features, including the physical environment or the built environment, as Anna called it, with housing and outdoor spaces. Then we have the social environment with civic participation or civic engagement and participation, but also social participation. And then there are the municipal services, which are left out a bit in the discussion of today, but still I do collaborate quite often with the municipality of The Hague, where I'm based. Because I'm also the chairperson of the knowledge platform Age-Friendly City The Hague. And our aim is to assess and measure the impact of municipal strategies to become or to be an age-friendly city. And this also encompasses the role of people with dementia. What we do is conduct a biannual monitoring evaluation of the age-friendliness of our city. And the first time we did it was 2020. We did one last year. And I know pretty sure I will be doing another one next year. And what we do is, together with a lot of older people from the Urban Committee of Older Citizens, we write policy recommendations for the municipality. Why do we do this? Because our city or our municipality has signed up for the global network of age-friendly cities. And that means that we committed ourselves to the cycle you see on the left. So the first 2 years you do a lot of plans, which involve older people as well. Then you do the implementation in year 3 to 5, and then you start the official evaluation process. And then based on what you find, you start the cycle all over again. And when I started my job, my position in The Hague, which was 6 years ago, I engaged with the municipality and they asked me, like, Joost, how age-friendly is The Hague? Because we've only been doing qualitative work, but we don't have anything quant. You're an engineer by background, you work in social work, so you must be able to find a solution to our question. I said, Mrs. Elderman, I will try and do my best, but I'm not sure if I can succeed. Because the lack of measurability of age-friendliness and also dementia-friendliness is actually quite a weakness in moving the agenda forward. We didn't have any standardized tools for measuring or evaluating the age-friendliness of cities. And in 2015, the WHO actually wrote in one of their reports, measuring the construct is too complex. Well, that's not really inspirational, is it, if the WHO makes such bold statements? So I said, well, to hell with the WHO, we're going to do it. So I put together a nice team of clinometricians, psychologists, gerontologists, and so on. And we developed a 23-question questionnaire, which is totally validated and transparent, and it's been cross-culturally validated now for 10 countries in Europe and beyond, and there are way more countries coming up. And what we do, we are able to capture age-friendliness of the WHO domains, plus an additional financial domain. And there are a couple of things that I want to show you, and then it brings me closer and closer to dementia. So we did a survey in 2020, 2022, and of course, these are the years of COVID. And we saw a couple of strange things, or not too strange, but remarkable things. First of all, we saw that the social participation levels plummeted in our city, which is quite easy to explain because the social meeting rooms that we have on the neighborhood scale were all shut down. People were too afraid to go out and interact. And at the same time, we saw the levels of respect and social inclusion go up. So apparently we had less ageism, less stigma in our societies. We saw an overall decline in the appreciation of the outdoor spaces and buildings. And that's like a little bridge that I'm going to use for the next couple of slides. And we also saw that the financial situation of people, which is the most important factor in experiencing dementia friendliness and age friendliness, plummeted as well. And that's because of the cost of living crisis that we've seen quite strongly since July 2021. So we have a lot of data. And then together with the municipality, we did clustering analyses. And we came up with 4 distinct clusters in our society. We have a rich one, which is all in the green, because they are well educated and they know the way around. We have a very poor cluster in cluster 1, people with a lot of financial problems. We have what we call the average satisfied Dutchman or Dutch woman, which is cluster number 3. And then we have cluster number 2, and we actually found that all the people with dementia fall into this cluster for some reason. And this cluster is a cluster which is affected by disease and impairment and also mobility issues. And we found that they score the lowest on the appreciation of the outdoor spaces and buildings and transportation. So the means to go out are hampered by impairment. What we also found, this group has quite a high number of females. Less people with or fewer people with a migrant background, lots of homeowners, and the quality of life that they gave themselves is quite high, 7.4 out of 10. So going to this other slide, what we found is that 2/3 of the older people need some form of minimal policy intervention, which are mainly the rich and the well-off and the healthy people. And that was quite new. So we discussed with the municipality to start investing or making new policies for people who actually need it. And that also includes the people with dementia. And we also found that people in cluster 3, like the well-off, and cluster 4 and 3, sorry, the well-off and the people who are just living their lives as normally as they can, could actually develop a disease or an impairment, including dementia, and could actually become a member of cluster 3. So we need more interventions in terms of prevention. So what we are doing with the municipality is also look at the so-called Dementia Inclusive Society, and it's very nice that the WHO published this new report 2 years ago towards a Dementia Inclusive Society. I think we can all read the definition, but it's something that we can all adhere to these principles, and it's an extension of the age-friendly publications that they've published in recent years. And what I really liked is that they had a model. And this model looks very much like the age-friendly cities model, but it has 2 additional petals. There is, on top, attention for safety. So safety and security for people with dementia, so that they can live their lives the way they want to live them. And then we have, on 7 o'clock, if you read it as a clock, 7 o'clock, there's carers support. So the family carers are finally getting a position in here. I don't know how this model actually came about and how it was derived. But I like the fact that this is more like a richer model than the original age-friendly model, and it also accounts for specific needs of people with dementia. Which brings me to this fantastic infographic that was already shown by Anne, but it actually shows the interplay between the social environment and the built environment, and also care and support needs of people. And what I like a lot about this infographic, it looks nice, to be honest, but it has a lot of attention for meeting places, both inside and outside, or indoors and outdoors. And what I really like about it is that this is also important for the social housing associations and project developers in our country, that it's really important to include or incorporate these design features in whatever they develop, whatever they design. And it's also a nice talking point for architects, to be honest. And what I also like about this Dutch infographic that matches up with initiatives from abroad. Because this is from America. I just took a couple when I was preparing the slides, but there's also a lot of attention in America being given to staying social, staying inclusive, staying engaged, staying connected. So all these social aspects are an integrated part of living well with dementia, so to say. So if we know that social meeting places are key, anywhere, anytime, how can we actually improve our cityscape in order to be more inviting, be more inclusive, and also be more dementia inclusive? Well, I would also start with, it's not about accessibility per se, but it's also with taking away signs of implicit and explicit ageism that we see in the built environment. A couple of years ago, we took The Hague and a nearby municipality of Zoetermeer, for all the people from the Netherlands who know that, but some people would actually call it a suburb. But we did a photo production study there about ageism, and we saw a lot of negative depictions of older people in the built environment. And actually, if you pay attention to it, it's quite shocking. So we had these cartoons, and there's a lot of like older people depicted there who are just grumpy or complaining about noise, but it's never positive, it's always negative. We have signs, and people actually say, there's a sign to an underground tramway station, which says it's forbidden to park your bike here, but it also says it's forbidden to park your mobility scooter here. So it is age inclusive, but in a negative way, so to say. So we studied all of these photos. We had hundreds and hundreds of photos. We studied it together with the municipality, and it led to quite a substantial investment program in order to take away some of these barriers because they were simply not on the radar at the town hall. Then what else do we do? Well, The Hague is very, very active in creating meeting places, and this is where the built environment integrates with the social environment. You see the map of the city with all these locations marked in orange, and these are the meeting places in the neighborhood that we call Haags ontmoeten. And ontmoeten means to meet or meeting, and Haags is like from The Hague. And it says it's your place in the neighborhood, and we have over 30, nearly 40 of these meeting places, which are run either by volunteers and by welfare organizations like Extra. And one of them that I particularly like is the one that you see here on the photo. It's actually in an op shop or in a charity shop, second-hand shop, where they have a corner where people with dementia can actually go to. Not just for having coffee or engaging with professionals like social workers, but also do some volunteering in this second-hand shop, like selecting goods, putting things in shelves, making sure everything looks nice. But there's also what we call a Dementake, like a dementia library where people can get information through books, but also try out assistive devices and so on. And it's all run through this charity shop or second-hand shop. And I think that when we create new concepts in a creative fashion with new ideas, bringing unlikely partners together, like this second-hand shop with social workers and people with dementia, I think we can create spaces which are inclusive and are really cost-effective, because it doesn't cost much, but it delivers quite a bit in social turnover. So that's just like a little sneak preview of what we're doing in The Hague, and I hope in the years to come, I'll be able to influence the policies at our town hall, and I will do my best. That's a promise that I'm going to keep. And then in a couple of years' time, you will hear from me what the actual turnout of these initiatives will be. Thanks.
Thanks a lot, Joost. And very interesting to see that if we do good things for people with dementia, it's actually good for everyone. And it just needs 2 padlets extra. How did you call it? Pedals extra. So we can do it. Vera will go around with the microphone if there are any questions right now for Joost. And we really have time for questions. So please use it. There's a question.
I'll lose it, yes.
So first of all, thank you for the presentation. I think it was very enlightening. My question was because the more I see about a dementia-friendly society and about the dementia-friendly built environment as well, the more I think, well, this would also appeal to me as, you know, like a neurotypical individual. Is there any research done on how a dementia-friendly society will also improve the lives of like the general public living there? Or because maybe it also can help, you know, getting a bit more funding from like government agencies or even, you know, put it on policy makers' agendas?
Well, it's a good point that you're raising, because I fully agree that whenever a society or the built environment is dementia friendly, it's also good for younger generations. But sadly, we don't have a lot of validation studies on that, just more like anecdotal. But yeah, I think it would be worth exploring also in terms of funding if such studies could be conducted.
Thank you very much.
There is time for another question.
Else you got one.
Ooh, then I need to think now very quickly. Oh, but there's one here, look.
Microphone.
So I'm Catarina from Portugal. My question is about the way that you operate these to happen. So what is necessary to some spot be an encounter for people with dementia? These like 50 spots that you have. What do you need to become a spot of that kind?
Well, we actually used to have more than 50, but then we had some austerity measures at the town hall, so the number were reduced and around 40, and I think we have 37 left. So what you need is you need to have a partner like a nursing home with a spare living room, or a community hall somewhere in a neighborhood with an empty space just like this where you can meet, and a bit of money to do to buy some furniture. Then you need to have a social worker, 1 or 2, and a bunch of volunteers. So it does take a bit of organization, and that's why one of the welfare organizations in The Hague is responsible for running these 40 locations. But because it's so successful, a lot of volunteers sign up, so it can be done.
You have, sorry to interrupt, you have a social worker in every space all the time?
Yeah.
Okay.
Yeah, and because there's also regular activities being offered, you know that people are coming in, and in times of COVID, they were quite essential for having people to engage with one another, because back then, when people simply didn't want to go out, it was essential to keep offering social work elements in a place like that. So it was they also offer means for debt relief or for finding your way through the healthcare system to apply for assistive devices. It's more than just social work per se.
Thanks a lot. So everybody can use the age-friendly questionnaire or not, Joost? It's available for the WHO?
Yeah, it will be posted on the WHO. We got a couple of languages coming up, mainly from Eastern Europe at the moment. So Polish is done, Russian is done, Romanian is done, Macedonian, Albanian. Portuguese is coming up before the end of the year. And we're going to have a couple of English-speaking countries like Ireland, the UK, Australia, New Zealand coming up also before the end of the year. And we got Hebrew now, so a lot of Italian, Spanish, it's all coming up.
So we can all use it and just add some dementia friendliness to it, and then you have an outcome for your age-friendly city. We will, oh, I need this. I want to be precise. Let's see, because we continue from the social environment, we now go to the built environment. And for the built environment, I need to have Leonie van Buuren here. Leonie is a researcher at the Eindhoven University of Technology, and she works at the Dale Academy. And uses smart architecture in buildings and to make people with dementia be more independent and we've worked together actually on dementia-friendly guidelines for the building of new houses, and we hope to finish this at the end of November. And her main focus for today will be on spatial orientation and wayfinding, so people with dementia will be more active and be more independent. So a warm applause for Leonie, please.
So thank you, Anne. So I'm Leonie from Buuren, as Anne already mentioned. I'm going to talk with you about the built environment and how it can guide you. So the built environment is what we see as the spaces, the houses we live in, how they are designed, how they're shaped, but also public buildings, buildings for care, and our streets, how they are created and designed. And from previous research, we know that the built environment can maintain or improve our quality of life. We also know that it can facilitate or stimulate behaviors. So it can nudge you in a way to take the stairs instead of the elevator if the stairs are presented more in front of the building rather than the elevators. And most importantly today is that we know that the built environment can cope with or counter symptoms of dementia. So we can do something with the physical environment to help people with dementia. And today I'm just focusing on spatial disorientation, as this is one of the first symptoms of Alzheimer's disease. And we know that the built environment can work on that. So what is spatial disorientation? It's not knowing where you are. So you are somewhere and you don't know where you are, and you also don't know how to arrive or to reach your desired destination. And if you are feeling lost, you can have feelings of stress, but it can also hinder you in performing your daily activities, and it hinders you in doing things autonomously well. That is what we all want to keep in our lives. So the spatial disorientation is not knowing where you are, and reaching your destination is called wayfinding. And wayfinding consists roughly of 3 steps, and it goes on and on. So it's processing the environmental information. So where am I? What information, what clues can I get from my environment? Second then is to develop a plan and make decisions. And then third, execute that plan. So how is wayfinding then involved in our daily lives? Well, you all arrived at this room, right? So how did you reach this room? So perhaps you were yesterday, so you remembered that you could follow this route. So you knew that that we were here. Or maybe you asked someone and he or she guided you. Or you used the environmental information features to get here. So maybe you had a coffee and then you remembered, okay, I have to go to the small place to get into the entrance hallway, go around the corner. Then you see the entrance, the main plenary hall where we had the lecture this morning. Walk on the stairs and then go left. Not go straight, but left, and you see the sign of 102. So you used all different types of architectural features and signage. So here there are some listed numbers, but maybe you used other mechanisms as well. So it's more about knowing how the space looks like and what you can use. But what we also know, if you know how a space looks like, or you have kind of created an image in your mind. So you see here a maze in Vaals, the 3-nation border place in the Netherlands, in Germany and Belgium. And there is a maze, and in the middle there's almost always, a tower in which you can oversee the maze, so you know how to get your way out of that maze. And that's also what we do in our daily lives. So we know, we have a kind of image of how this building looks like and how to get to your destination. However, if you get dementia, that skill creating this cognitive mental map disappears. So we have to deal with that part. Also, what is also disappearing is the memory knowledge. So remembering that you followed a certain route yesterday for today as well, that's also disappearing. But what stays is that people with dementia can still make sub-plans, make smaller plans. And we know from research that people with dementia can still execute wayfinding decisions if the built environment is designed properly in suitable architecture. And these are some examples of nursing home corridors. And to me, they are not really enabling people with dementia, in my opinion. But maybe you think differently, but that's how I see it. There are long corridors without any little light, endless doors. So we can do that better, I think. So how can we do that better? So I want to take you on in some examples how we can improve the built environment. So, and we're looking a bit towards from now towards the future. So I'm going to show you some design principles of current knowledge and literature. Then I want to show you something about what we are developing in smart architectural solutions. And then some dreams and exploration we have to new spatial possibilities in guiding people. So first, what is already known in literature? So you can see here 2 images. And what we know, for example, from previous literature is that you should make use of articulated architecture. So no long straight walls, but have some distinctive features. You can also make use of colors. If you make use of daylight entrance, people can, of course, look outside and see where they are in the environment, but it also provides sufficient daylight and sufficient lighting to get an overview of the space you are in. What you can also use is that the corridor should be wide enough so you have really that overview, so you can really look into the space and how it looks like. What you shouldn't do, or what you should avoid, is the number of amount of decision moments. So if you have to choose to go straight, left or right, try to minimize that number of decisions. And if you have to make that decisions, make them distinctive, because now do you know which way to go if everything looks absolutely the same. And what also could help is decrease the number of doors. So because the closed doors don't show you what is happening behind it, so you don't know if that's the place you want to go or not. So these are just some things which we do know already. But together we are also developing smart architectural solutions in a way that we look into technology embedded into the architectural features. My professor, Massimo Amadi, developed a guiding environment. And I have a video to explain to you what it is. It's spoken in Dutch, but the subtitles are in English. And I think the image says enough about what we are doing in this smart way.
Nederland vergrijst. Ons land kent nu zo'n 280.000 ouderen met dementie en de verwachting is dat dit verder zal toenemen. Om de zorg te ontlasten werken we aan innovaties. Technologische aanpassingen die mensen ondersteunen, die meedenken, meevoelen. In Arnhem staat ons inspiratiehuis. In deze empathische omgeving onderzoeken we hoe technologie voor ondersteuning kan zorgen. Hoe een huis taken van een mantelzorger kan overnemen. Zo bouwen wij stapje voor stapje aan de empathische woning.
Goedemorgen, Els.
Waar ondersteuning ervoor zorgt dat mensen met dementie hun dag- en nachtritme kunnen behouden. Opstaan als dat moet. Zo worden ze ongedwongen ondersteund en houden ze het ritme van de dag.
Goedemiddag, Els. Vergeet je niet te eten?
Deze vorm van begeleiding zorgt ervoor dat mensen beter voor zichzelf zorgen. Hierdoor blijven ouderen met dementie langer zelfstandig wonen. Met minder zorg en minder zorgen. Staan ze op tijd op, eten ze regelmatig en genoeg en gaan ze slapen wanneer de avond erom vraagt. Ervaring opdoen staat centraal in deze woning van de toekomst. Waarmee we mensen straks ongedwongen kunnen ondersteunen. Want de techniek van morgen staat ten dienste van vandaag.
So what you could see is that we are trying to embed smart technologies with sensor technologies, but also lighting cues, projections into the built environment to help people guide them throughout their day. So this is a pilot building, or proefwoning in Dutch. And in the next phase, we are going to implement this system into assisted living facilities to test it with people with dementia, and later on to implement it in houses of you and me to help people living longer independently. So this is still something we are developing at the moment. So lastly, I want to show you some dreams and explorations we have about new social spatial techno possibilities in wayfinding architecture. We developed these ideas with researchers, students, master students of the study architecture, professionals in care, technology, housing, and public health. So this is just an image to show you some examples. Disclaimer, it has not been tested yet. So we don't know if this really works or not. So this is really the exploration and the thinking about new possibilities. So for example, we can place some social functions at strategic places, so people are nudged towards those places, or use interactive art to get people towards a certain destination. Use this guiding sensor technology on the ground projected, so maybe everyone gets a personalized routing towards the village. You can make use of different materials and walking paths, maybe natural boundaries to work with. So these are just some explorations, ideas, and we are hoping to test them and validate them with people with dementia themselves, how it really works. So that was in a nutshell what we do about dementia-friendly architecture that can guide you. If you have questions or feedback, I would love to hear. So thank you.
Thanks, Leonie. And we have time for questions. I see one there and one here in front. Oh, and one in the back there.
Hi, thank you. Does this work? Yeah. Hi, that was a really interesting talk, thank you. I have a question about some of your future plans. So you said that eventually you'll be testing some of the ideas in people's own homes, and just wondered if you had any thoughts on how to work with people with dementia to encourage them to make these changes in their homes, potentially if they don't want changes made, how you might do that.
Yeah, good question. So therefore we start. So our dream is to implement it in people's homes, indeed, but maybe also to connect it with other care services, digital services as well. So that I think if we want to implement it in people's homes, maybe you have to work with home care organizations as well to get this implemented. Does that? Yeah.
Thank you.
Hi, thank you so much for your talk. It was very interesting. Also the pilot video with the cues from the environment with the light and projections, really interesting. Do you have any thoughts on how this also could feel for the person with dementia, for example, it could feel as a little bit stigmatizing if you ask, like, did you don't forget to eat, or having these arrows on the floor, they could feel treated as a child a little bit, what they, of course, don't want. Do you have any thoughts on that?
Thank you for your question. Indeed, you're right. That's a very thing we should very look into. Right now, we've focused on possibilities, creating possibilities, which could work, and it should be tested more and more with people with dementia about how they feel about it. Also, if the sandwich is working or not. So there was a sandwich displayed on the wall. There was some tests about if a cartoon image or a photograph of a sandwich was working better, but still it is not that. So it can be improved in that way. Yes.
Thank you so much.
So the last question over there, and then we will continue.
Thank you. Hi there. Have you actually asked any person living with dementia about the designs? Because a lot of the designs wouldn't work for me. Your bold patterns on the walls. My Alzheimer's affects my visual awareness, and they look real. So that if I was walking into that would look like I was walking into a big flowery field. Like the flashing lights on the floor, that wouldn't work for me either. That would really hurt my eyes. So it's maybe worth talking to people with dementia in your design practices?
So in the research more without the smart elements embedded, then of course we talked a lot with people with dementia. We observed people with dementia and how they use the built environment in later stages of dementia especially. And within this, the smart technology aspect, I think it's the same as what you did ask. There are some questions asked yet, but in the next phase we should ask very much more questions about people, how they really experience it. This is, at the moment, this test house is located in an industrial area, so we have to invite people with dementia towards their places, and that's a bit harder. So therefore we want to implement it into assisted living facilities so they are already there, so we can really ask people how they feel about it. And if they don't like it, then we have to go back to the drawing room.
Okay, thanks a lot, Leonie. And we will continue with the next perspective on housing with dementia. And I need to say, really good questions. I mean, we always need to think or ask ourselves, is this what solves problems or is it creating problems? I mean, this is all testing. And I think the goal of this part is to be more autonomous, and this is a way to do so, but does it work? We need to keep close to the people with dementia themselves. So the last perspective on housing with dementia is right on the bottom, care and support. And for this perspective, we've asked Vivian van Raaij of healthcare organization Tante Louise. Dementia is progressive, and there might be a point that healthcare is needed. And Tante Louise is experimenting with a new concept, combining psychosocial interventions, learning programs, technology, and temporary stay. And for that, Vivian will tell more about that. So, warm applause for Vivian.
Thank you very much. At first I have to apologize. I have catch a cold. Sometimes I will take a handkerchief to sniff my nose. It's possible. At first I want to tell you something about Tante Louise. Tante Aunt Louise in English. We have 15 nursing homes, 1 hospice, and we have a small amount of home care, including dementia case management. In one of our newest nursing homes, opened in 2018, we started to work with a daily program based on different interventions with the aim to activate people with dementia who are living with us. We learned that an active program with personal goals had an effect on the sleeping behavior, and people with dementia slept much better, and there was less shouting and wandering in the night. We believed that those people could live at home and only come to us for a daycare program. But our traditional daycare program is organized from 10 in the morning till 4 in the afternoon, and from Monday till Friday. All participants start at the same time, do the same activities the whole day. We learned from our insights from our nursing home that when we developed a new kind of daycare, and people with dementia and their informal caregivers were involved in these developments. Van thuis uit, we call it from home coming to us, that means. In short, it means every participant has a personalized program matching with their own goals, wish and situation. It offers 3 different locations. A day activity center that's open 7 days a week from 10 in the morning till 8 in the evening. And it offers visitors a daily structure and a meaningful day schedule in 5 different areas. It's a small, I hope you can read it, but we do about sports and games. Also digital games, technique and nature and climate, arts, theater and music, and the other one is cooking and personal verzorging. Personal care, sorry. The other different location is the interventions at home. home actions independent deploys technology and social innovations in the home situation. Health education from the health point located in the day and activity center. And the last one is a temporary stay. We have 2 guest apartments which are used to help people with dementia and to support them with targeted advice when going home. So they can stay at us for a small time, and then we can offer them the same activities as in the day activity center. And those 2 apartments are located in the day activity center. Now, how does Van Thuis Uit work? At first, there's an intake. There's a person with dementia, and its informal caregiver is coming to us. They get an intake, and then they get a personal screening. That screening is made from different questionnaires. And then we are looking at which intervention is the best for you. So we have active aging programs, we have day rhythm programs, we have implicit learning programs, psychosocial assistance, and services and use of technology. And we can offer them at home, but we can also offer them at the day and do center or at the health center. And we also can offer them at the temporary admission, dus in those 2 beds for temporary admission. We have this methodical interventions, and the aim of these recovery-oriented interventions is to retain people's skills for longer or to teach them new skills with the support of a multidisciplinary team. We know that we can learn people with dementia new things. And we hope to learn them. I have an example from a person who came to our day and do center, and that person wanted to make coffee again. He didn't know which steps he had to take. So we learned him how to use a coffee machine, but there was one problem. In the day and do center we had a different coffee machine than at home. So at home he didn't know what to do. This was a learned lesson for us. The implicit learning programs consist error and free learning and emotional learning from the associative learning and the EDOMA program. EDOMA is a special program for the informal caregivers. Then we have psychosocial assistance, which contains systematic theoretical approach, a behavioral cognitive approach, creative social care and informal care support. Then we have active aging. We have special nurses working at Tante Louise who learn the people with dementia which steps they have to take to act what they want to do. So I just mentioned the person with who wants to make coffee again. There are different steps. You have to buy coffee. You have to put water in the machine. You have to press the button to make the machine work. You have to put a cup under it, or you have to put it in a cup. People doesn't know what steps to take. They learn together with the active aging nurse which steps to take. When they know what they have to do together, then the active aging nurse goes away for one step. When that goes well, she goes away with 2 steps. So at the end, the person with dementia can make his coffee all on his own. So the active aging nurse, she exercises with the person with dementia. She looks at the nutrition and she gives cognitive training. Then we have day rhythm programs, which are recreational, methodical, and demand-driven. And then we use devices and technology deployments, and we give information and instruction. We ondersteunen, support, implementation, and we use the data to develop more. More into the program, it consists of a mix of recreational and methodical activities and social guidance. Very important, do not take over tasks in the face of not feeling well. We are never too old to learn. And with reactivation, we want to increase self-reliance by activating in the physical, cognitive and social domains. And we give psychosocial support and health education, not only to the person with dementia, but also to his informal caregiver, and also to entrepreneurs or people living in a municipal. And so we have a grocery store in Steenberg. It's a small place in the south of the Netherlands, where we make an appointment when people with dementia are coming to get their groceries, and they forget to pay for them. Those people are not taken over by the people working at the grocery store, but they let them go because they know those people are going to the day and activity center or to one of the nursing homes, and we send the bill to the nursing home or to the day and activity center. So the person with dementia is not anxious because an angry person who works at the grocery store is coming to him from, you have to pay. Future perspectives and strategies. We are at Tante Louise, we work together with a lot of organizations. We are a participant in a board. I believe Alzheimer Nederland is also a participant. It's aimed at personalized medicine approach for Alzheimer's disease, advancing and personalizing diagnostics, and lifestyle intervention. And we also participate in QLEAD, quality of life by use of an enabling AI in dementia, and Spread Plus, sustainable and personalized advances in dementia care. That was my presentation.
Thank you, Vivian. And if I listen to it, I'm thinking, okay, so conservative care is more caring for someone and taking over the tasks. And with this active, more active type of caring, you try to give back the control to the people themselves and to relearn everything so they can do the things that they want to do themselves. Yes. Okay. So there's time for questions. Are there any questions? Yeah, there's a question.
It's a very interesting talk. I'm Helen from Sweden. At our little community in our city, we have also daycare program, exactly like the traditional. And people do enjoy the group. Okay, I think I could have missed it. Your intervention, is it? Do you do it individually with the nurse, or you do have also a social group?
We also have a social group. It is what the person with dementia wants.
Yes.
So he comes with a goal. I want to make coffee. I want to go to the grocery store by my own. And the activity nurse of the active aging nurse is exercising with one person because they are fully focused on one person. But when it is a group intervention, she will stand in front of a group.
Okay.
Or work together with a group.
Do they come at individual times or they come at a
individual
certain...
times?
Okay.
Not totally, because we want to cluster. We want to put them to make it organized easy for us. There are different moments to come, but in the traditional way, they all come by taxi. But in the new way, they come by their own, and some with a taxi. That's the difference.
We talk later.
Okay.
Okay, so if the goal is to make friends, they come to make friends. Or if the goal is to exchange experience, they come to exchange experience. Is there another question? No more questions? Then thank you all for coming. And if you have any more thoughts or whatever, come forward, speak to us, and we can discuss it later. Thanks.